So we will measure urea in plasma, serum or urine. Okay, and we use here modified Berthelot method, and this is a endpoint method, and we have kinetic method also. It will be discussed later. This is endpoint method. So the method is modified Berthelot method. So this is the structure of urea, CONH2 NH2, and here C comes from carbon dioxide. One ammonia will come, NH2 will come from ammonia, another will come from amide group of aspartate. Okay, so 3 atoms from where it is coming: carbon from carbon dioxide, one N from ammonia, another N from amide group of aspartate. This is the mnemonic you can remember. Urea will be forming in the hepatic cell. So in mitochondria, hepatic mitochondria and hepatic cytoplasm. Ornithine will be inside mitochondria. Citrulline, Argininosuccinate and Arginine. This will be in the cytoplasm. So the mnemonic is O, Ka you can remember, or cow you can remember, but this will be better. From ornithine if you start, it is inside the mitochondria and the cytoplasm. Citrulline, Argininosuccinate and Arginine will be broken down to form urea. 4 steps you have to remember for urea synthesis. One is transamination. So one is transamination, another is oxidative deamination. Ammonia will be transported and later ammonia and carbon dioxide will combine together to form urea. So how transamination is happening? Alpha amino acid will act with alpha ketoglutarate. Alpha amino acid will form alpha keto acid and alpha ketoglutarate will form glutamate. And glutamate, after oxidative deamination, it will form ammonia, and after combining with carbon dioxide, it will form urea. So urea is nitrogen substance, and where you can see increased urea and decreased urea. Normal increased protein intake and hypercatabolic state, also hypercatabolic state like sepsis, tumor or malignancy, their urea can be increased. In male, protein is more, so urea is more for protein consumption is there more. So urea is more for male and less for female. And cortisol, injection cortisol or synthetic cortisol analog, if you give, there will be increased urea because there will be stress, and for stress there will be protein catabolism, amino acid will be formed and neoglucogenesis will be done. So there will be breakdown of amino acid, so there will be urea. if you have to tell like how urea can be increased in condition like, you can say pre-renal, renal and post-renal causes. Pre-renal causes can be dehydration, so there can be vomiting and diarrhea will cause increased urea, and after that consumption of increased protein, hypercatabolic state in injection, cortisol injection, all that will increase that urea. Renal cause acute glomerulonephritis, there will be glomerular injury, so it will not be excreted. So you have to remember two things. Urea is forming in the hepatic cell, parenchymal cell, and it is excreted through kidney. So any problem, decreased perfusion to the kidney like heart failure, there also urea will be increased. And liver disease, urea cannot be formed, so decreased urea will be in liver disease. And post-renal causes will be malignancy, prostatism, and what happens here, that urea will not be excreted through urine, so there will be backflow and urea will be increased into the blood. If you have shock also, so that time also urea will be increased. And another thing is nephrolithiasis, also will be obstruction to the urine excretion, that time also urea will be increased. So malignancy, nephrolithiasis and prostatism. Here what happens, if you see the kit, there will be 4 bottles. One is for buffer, one is for urease reagent and enzyme reagent, another one is for chromogen, and another one bottle will be for standard. Okay, so here urea will be broken down by urease. We get urease from fava beans or dal also, we get urease. So what happens, urea will be broken down with the help of urease. Urea, with the help of urease, it will be broken down to ammonia and carbon dioxide, and ammonia will react with phenolic chromogen. So the chromogen will be having that compound phenolic chromogen and hypochlorite also. So it will form the green colored complex. So the color will increase with the concentration, increase of the concentration of urea into the sample. So what is the difference between serum and plasma? Hydrogen will not be there, and so there is a difference between serum and plasma. After plasma, after blood is clotted, we are centrifuging and taking out the serum. So this is the principle also, and the color will increase with the increment of the urea into the sample. So increased color, green color means increased urea. So this is the principle, and the reaction is this one. And we will measure that green colored complex into the colorimeter or spectrophotometer, and we will get concentration and absorbance. You have to be very careful while seeing that result. You will not write concentration as absorbance and absorbance as a concentration. There are 2 different terms. You have to check properly which is absorbance and which one is concentration. You are normally, the report will be, you are showing the concentration, and absorbance how you will deduct from the formula that concentration can come out. So you have to check very properly which one is the concentration and which one is the result, concentration and which one is the absorbance. Both are not the same thing, so you have to be careful. In serum or plasma, the normal urea level is 14 to 40 milligram per dl. And in urine is 20 gram per liter. Up to this much it is accepted as normal. Urine. So you will get the reagent, buffer reagent will be there, enzyme reagent will be there, chromogen reagent will be there, and urea standard will be there. Okay, in the all that reagent, the things will be phosphate buffer. Buffer will be having phosphate buffer, nitroprusside, and phenolic chromogen, and along with it there will be detergent, preservative, and stabilizer, and one standard will be there for urea. So urea one bottle will come along with it. Ten to the power minus 6 liter means 1 microliter. Okay, and 1000 microliter equal to 1 ml. This thing you have to know. Micro 10 to the power minus 6 liter equal to 1. 10 to the power minus 6 liter equal to 1 microliter. And I told prostatism. Prostatism is enlargement of the prostate, and there will be compression to the urethra, so urine will not be excreted. It's a prostatism. The term is prostatism. B for blank, S for standard, T for test. So, what we will do? L1 reagent. This one will take 1000 microliter for 3 test tubes. L2 is the enzyme reagent. Will take this is 1000 microliter, and L2 enzyme reagent will take 100 microliter, and distilled water for blank 10 microliter, standard 10 microliter. What they have given already, that is supplied. And test, what is the sample you are taking, from that you will take 10 microliter. Okay, now you have to incubate. You have to remember L1, it will be buffer diluent. You have to incubate it after this point. Okay, you can incubate in the hot water bath for 5 minutes, or in room temperature 10 minutes. In hot water bath it is 37 degree, in room temperature it is 25 degree centigrade. So hot water bath it will incubate 37 degree centigrade, and room temperature you can keep around like 25 degree centigrade. So if you are using hot water bath, 5 minutes you will incubate here, then you will give the chromogen. This is 200 microliter. Then after that also you will incubate. If you are putting in the hot water bath 5 minutes, and if you are keeping in the room temperature, then you will incubate for 10 minutes. Then and at 570 or 578 nanometer wavelength, you will measure the color intensity, you will measure the absorbance or optical density. Now you have to do the calculation. This is the procedure. So, absorbance of taste, you will get this one, you will get what is the absorbance, and absorbance of blank you will get from here what is the absorbance, divided by absorbance of standard minus absorbance of blank into standard concentration of standard. That one will give you the result. Here you will get one numerical value. So it will be result. So after doing everything, there will be one point where you will write the result. How much you have got the urea in the given sample, you have to write the value. That result you have to write. Yeah. In hot water bath, the temperature will be more than the room temperature. In hot water bath, there will be water inside there. They uniformly that heat will be distributed to the test tube. So you are incubating. If you are incubating, so it will become faster. The reaction will become faster. So it will take less time. But if you don't incubate it, keep it in room temperature, it will take much time. For this one, for this, in the reagent and all that, there can be a sodium azide can be present. So what happens if anyone gets it spills or get contact to skin or mucosa, you have to wash it with thoroughly with water. Okay, and this one you are measuring the ammonia. So any ammonia salt shouldn't be contaminated. So fluoride of ammonia or heparin heparin of ammonia salt will not be added anywhere to this reaction. And chromogen will contain chlorine. So you have to be careful that not to keep the bottle open for longer time. The chlorine might get out. So you have to cap the bottle a bit faster if you can do it. So in every kit there will come one literature. It will be written here. If you want to check by yourself, just go through the literature and check it. Okay. So where the urea can be lesser, you can see in pregnancy, in children and in female. In male it is higher than the female. In pregnancy there may be hemodilation is there, so there can be decreased urea, and in children also their consumption may be less, or their comparatively their urea is lesser, and female also less urea. Slightly. It's not pathological, physiologically it is higher. Slightly. Another thing, if anyone having GI bleeding, blood protein will give rise to urea. So GI bleeding can give rise to increased urea. So urea concentration will be increased by high protein diet, increased protein catabolism. Catabolism you can see in malignancy, sepsis, or any Malignancy, sepsis, burn also. Burn also you can see the urea. What happens? You will lose the water. So dehydration will be there, and protein whatever it is decomposed, so that can metabolize. So urea will be increased. Treatment with cortisol or its synthetic analogs, dehydration and decreased perfusion to kidney like heart failure. And post-renal causes will be malignancy, nephrolithiasis and prostatism. Because increased back diffusion. So post-renal causes will be due to increased back diffusion. And it can measure up to 250 milligram per dl very properly. After that, if you feel it's more, linearity is crossing, so you have to dilute the sample, then you have to measure it. It is 578 or 570. Anything you can take. Actually filter 570 and you can take up to 578 also. It's not range. It's a yellow filter, and thing is there is a range, maybe not for 8 millimeter, nanometer. So the range will be more, but it will come better 570, or you can take 578. Sodium azide. Sodium azide will be present in that reagent. It is one of the component. So if you get any spillage with the skin and it contacts to skin or mucosa, just wash it because it is irritant. First you will write the method, then principle, then reaction, reagent, procedure, there procedure in that, all the steps and calculation also. Then you will get the result. You have to write the result in exam. This is very much important, and you will be very careful not to write concentration as a absorbance or absorbance as a concentration. After result, you can give reference range that I have told, 14 to 40 milligram per dl in urine, serum, and 20 gram per liter in urine. Then you will give clinical importance. So write like that, you will write. This is a endpoint method. We can measure the urea with the help of kinetic method also. Kinetic method will be taught later, not now. And what is endpoint method? Endpoint method means where there will be equilibrium, and substrate and enzyme affinity is more, and after incubating you are getting reaching up to the point of equilibrium. There you are measuring all that. So it's an endpoint reaction. Enzyme and substrate affinity is more, and there will be equilibrium in the case of endpoint measurement. And how ammonia is detoxified in brain, you will read it. We'll discuss later. We'll try to discuss later, and you better study that one. Okay. Anything else you want to know or ask? Where you can see the increased urea and decreased urea, and what is the pre-renal, renal and post-renal causes. In pregnancy, maybe due to hemodilation. Okay, so and the children and female relatively lower than the male. Pathological low of urea. Backflow will be there, so urea will be increased in the blood. It will not be decreased. You told about decreased, right? Decreased urea. It is not, urea is not secreted, so it will, and not reabsorbed also. Okay, it's not secreted, and decreased urea I have to check. Normally urea, no, we don't see decreased urea. Because it is decreased urea means we feel it is better. Like below 14, if it's you have urea, so your kidney and your liver is very much functional. It's very good. If it's more, then only problem will arise. In liver disease, there will be decreased urea, but there is stages of liver disease. First liver increase in size, and then it is like cirrhosis, means all that cells are already gone. So when the cells are already gone, you can say that urea will not be formed. But when that is increasing in size, that time what happens, I have to check. Anything else? They have written in liver disease, urea will be reduced. So liver disease, all the things will come most probably. But still, I have to double check it, because when that's increasing in cell size and all that, so that time can it increase in the urea production? Okay. Otherwise, in cirrhosis, it has to be low, because that time cell is already gone. So anywhere, all the reason I have told that can be cause of increased urea, that will be the reason the urea can go up to 250 and beyond that. So there can be dehydration, vomiting, like normally it doesn't, it depends on the severity and sepsis, all that, and hypercatabolism state. So it can go up to 250 and beyond that. And thing is, another thing, try to mix well. All that reagent you are doing, putting and everything, just try to mix well. And in kinetic, with the help of kinetic method also we can measure urea. This is the endpoint method, modified Berthelot method, and we have other method, kinetic method, to measure urea.